gentlemen, the time is ticking and here is the time. Shall we all rise to welcome the procession of the Vice Chancellor? Please, no more movement. Do not stand in the way of the procession. And please do not exchange pleasantries with the procession. We remain standing, ladies and gentlemen, as we observe the University Anthem.
The Deputy Vice Chancellor of Research, Technology and Innovation, the Registrar, the University in Nigeria, the provost in representative capacity, deans of various faculties, distinguished ladies and gentlemen. Today, we are gathered for the 298th inaugural lecture of our university titled The Quest and the Conquest of Community Eye Care, Minding the Gaps, to be delivered by Professor Feyi Grace Adepoju. Professor Feyi Grace Adepoju was born on 2nd October 1967, a distinguished scholar, consultant ophthalmologist, and humanitarian. She began her education at Igosun Early School in 1978 and completed her secondary education at Cornea Baptist High School in Jago in 1985. She proceeded to the School of Basic Studies at Adepoju University, Zaria, and later obtained her MBBS degree in 1991 from the same university, graduating as the best overall graduating student of her set, winning the prestigious Alba Award and several other prizes. She joined the services of the University of Ilorin in 2001 as a lecturer 1 in the Department of Ophthalmology. Through dedication and excellence in teaching, research, and clinical practice, she rose steadily through the academic ranks to become a professor of ophthalmology in 2011. Her professional training is extensive, with a certificate in community ophthalmology from the University of Cape Town, South Africa 2006, a master's in community eye health from the University of London 2008, on Commonwealth DFID scholarship and advanced training in Arabian Eye Hospital, India. She is a fellow of both the National Postgraduate Medical College and the West African College of Surgeons. She holds international professional qualifications, including Fellow International College of Surgeons, FICS. Professor Adepoju is deeply committed to community ophthalmology and blindness prevention. Over the decades, she has headed over 300 community outreaches, screened more than 200,000 individuals, and performed over 20,000 sight restoring surgeries. Our health advocacy extends to mass media, including our award-winning films, You Are My Eye 2011 and Still Water, which have reached millions of viewers across Africa. She has published over 72 scholarly papers in reputable local and international journals, authored 4 books, contributed chapters in several others, and presented at national and international conferences. She serves as a reviewer for 8 journals and examiner of undergraduate and postgraduate learners. Her leadership roles include Director of Medical Education Resource Center, University of Ilorin, Treasurer of the African Ophthalmology Council, President of Women in Ophthalmology, and Vice President of the Diabetic Society of Nigeria. Our awards include the Excellence in Ophthalmology Vision Award, ZOVA 2021, the Innovative Prevention of Blindness Award, and several academic and humanitarian recognitions. Beyond academics, she is a reverend and youth pastor, a gospel actress with over 100 films, and founder of NGO dedicated to supporting the underprivileged. Professor Feyi Adepoju is married to Reverend Adepoju and the woman is very children and grandchildren. She is celebrated for her academic excellence, clinical expertise, leadership, and humanitarian service, and for her lifelong commitment to the fight against preventable blindness in Nigeria and Africa. Please welcome with me Professor Feyi.
The Vice Chancellor, the Deputy Vice Chancellor, Academic, Management Services, Research, Technology and Innovation, the Registrar, the Bursar, the University Librarian, the Provost College of Health Sciences, the Dean, Faculty of Clinical Sciences, Deans of other faculties, Postgraduate School and Student Affairs, professors and other members of Senate, the Chief Medical Director, University of Ilorin Teaching Hospital, all the principal officers of UITH, directors of various units, heads of departments of ophthalmology, heads of other departments and units, head of departments, clinical and non-clinical staff of UITH, my Lord, spiritual and temporal, distinguished invited guests, members of my nuclear and extended families, great students of the University of Ilorin, and especially the College of Health Sciences, gentlemen of the print and electronic media, distinguished ladies and gentlemen. The Vice Chancellor, sir, distinguished guests, it is a rare honor and privilege for me to deliver the 290th inaugural lecture of our great university. For me, today is doubly special because it coincides with my birthday. I acknowledge my Creator, the Almighty God, the giver and sustainer of life. Romans 8:30 declares, those he predestined he called, those he called he also justified, those he justified he also glorified. This is my testimony. To him be all the glory. This lecture is the third in the Department of Ophthalmology, following Professor Abdurrahman Olaro Bey Mahmood in 2012, The Sight and Rights of the Blind, and Professor Adepoju in 2023, Illusion to Vision, a symphony of triumph and triumph of child eye health. By God's grace, I carry that torch forward today. My name is Grace, and truly I'm a product of grace. I lost my father, Joseph Alalade Ayoride, before my first birthday. I was raised by my prayerful resilient mother, Madam Sarah Ayoride, who remained my role model in faith and determination. I attended 6 different primary schools before finishing at Igosu LGEA, where Grace singled me out as the head girl and multiple prize winner. Secondary school at Oyi Baptist High School in Jabo almost ended before it started. After the first year, fee rose to 135 per term, naira, and continued seemed impossible. 2 people rescued my dreams. My late aunt, Mrs. Elizabeth Adepoju, who took me into her home in Ofa. I trekked the 5-kilometer journey to and fro, a rugged preparation for my future community eye care. My English teacher, Dickie Embo Titiloy, later volunteered to take me to school daily in the 4th year. With God's help and support of these people, I graduated as the head girl, best overall student and winner of multiple subject prizes, including mathematics, English, biology, physics, geography. Oyi Baptist High School grouped me for drama, debates, newscasting, and quizzes, where I proudly represented my school on several occasions. At Ahmadu Bello University, Zaria, There was another challenge. I had no textbook of my own and almost no notebooks. Yet, Providence saw me through. I graduated in 1991 with the Alba Award for the best graduate medical student and prizes in all the 5 subjects. My elder sister, Mrs. Oyeleke Felicia, who stood in as a mother, father, and sister. To you, I remain deeply grateful. I initially leaned towards general surgery and was encouraged to go into 1G by my teachers and women in Nigerian group. But a turning point came after an exhausting 72-hour emergency duty. Dr. Musa advised me, Grace, follow your convictions. My heart resonated with ophthalmology. After witnessing the findings of Professor Adenike Abiose, here was a specialty where I could merge community service, precision surgery, and my passion for singing. I was initially called a singing surgeon, but eventually veered into Christian movie, and I'm privileged to have acted in over 150 movies. I began residency training in ophthalmology in the year 1993 as a medical officer with Dr. Lupe Ademola Kupola, Dr. Kola Wale Ogunjimi. At that time, UIT was not accredited for postgraduate training, so we rotated across Ibadan, Kaduna, and Lagos. I remain grateful to Professor Olurotimi Fakeye, who played a vital role in ensuring we obtained the needed training, and to Professor Weye, who once told me at the verge of being left behind, find a place also, I will single-handedly run the department. That sacrifice paved way forward for me, and I am grateful. I also owe so much to Professor Victoria Pam, whose mentorship at Guinness Eye Hospital Kaduna helped me in winning Dr. Ilorin Prize for Best Candidate in Part 1 at the national exam. I joined the University of Ilorin in 2001 as a lecturer and became a professor in 2014. Today, I stand before you, not merely to present the science of community eye care, but to share the soul of the work, a journey of light amidst darkness, a journey in an uncharted waters, fueled by a quest to address the millions of rural community dwellers who do not have access to care. I will present on the conquest, highlighting the gaps that exist in the eye care system in Nigeria and how we have focused on minding these gaps. An inaugural lecture is not merely a tradition. It is a celebration of academic pursuit, a testimony of expertise, and an opportunity to inspire particularly the younger ones. Your background should never hold you back. I had a memorable event during the master's program at UK. We visited the No restaurant where blind staff ran all activities. We were blindfolded, served meals, and later asked to identify what we had eaten. None of us got the correct answer, revealing how powerful vision is and how daunting life becomes without it. This experience gave me an understanding of the challenges of the blind and strengthened my resolve to fight avoidable blindness. The eye acts like a camera, but the actual picture we see is formed in the brain. The exact location of this visual screen in the brain remains unclear. The eye is a complex organ. The complexity of sight is a reflection of God's wondrous design. Vision is its primary function, but the eye also contributes to beauty and aesthetics. The visual acuity is a very simple test to assess how well an eye is seen, usually tested one eye at a time. A normal visual acuity is 6'6" at 6 meters. That means what the eye should see at 6 meters is seen at that distance. There are different categories of visual impairment, but WHO defined blindness as presenting vision less than 3 meters in the better eye, and in the absence of an appropriate vision chart, inability to count fingers in daylight at a distance of 3 meters. Visual impairment is classified into mild, moderate, and severe. This grading provides a quantifiable measure of how well a person can see and is a key component in assessing and monitoring our health. It refers to the sharpness or clarity of the vision. Globally, over 2.2 billion people live with visual impairment, 43 million of whom are blind. Regrettably, 90% of blind people live in low and middle income countries. The common causes are cataract, uncorrected refractive error glaucoma, 80% of these blindness, ladies and gentlemen, are avoidable. In Nigeria, 0.78% of the population is blind, cataract accounting for about half of the cases. Again, 80% of these are avoidable. These statistics are not numbers. They are people whose potential is deemed by avoidable blindness. Avoidable blindness is either a blindness that is preventable or treatable. Treatable blindness usually occur from cataracts and refractive error. Ladies and gentlemen, there are several risk factors for blindness. An aging world brings with it a predictable increase in age-related conditions, particularly cataract, glaucoma, and macular degeneration. Adepoju et al. In the year 2005 found a higher ocular mobility and blindness among persons above 60 years. The burden of blindness is not carried equally. It is heavily skewed by gender. Women and girls face a disproportionately higher risk, often due to a complex wealth of cultural, social, and economic factors that limit their access to timely and effective eye care. They may be less likely to have the financial independence to seek treatment or the social agency to prioritize their own health needs over others. Adepoju et al. In 2020 found more men present for services than men, even at free or subsidized points. Beyond the biological and social realities, eye health is fundamentally tied to our individual circumstance. Poverty and literacy forms a virtuous circle. And only here Adepoju et al. 29 found poverty and illiteracy as a high risk factors for non-uptake of orthodox eye care. Geography also plays a critical role. For those living in rural areas, the scarcity of eye care facilities is a significant barrier. Long distances to clinic, poor referral system, and a lack of trained professionals often means that a simple, treatable condition can progress into irreversible blindness. Adepoju et al. In the year 2011 and in 2014 reported a majority of the eye care centers and human resources are located in urban centers. This geographic and economic disparity often leads to late presentation for treatment. This delay is typically a result of multiple factors: high cost, deeply ingrained cultural belief about illness, or simply a lack of awareness that their condition is treatable. In some cases, the very act of earning a living can threaten sight. Occupational hazard, such as those faced by farmers, can lead to irreversible eye damage. Workplace-related accident and injury were reported at Adepoju et al. In 2007. And however how well-intentioned, there are several harmful practices serving as another cause of vision loss. The use of traditional eye medicines, self-medicating with unproven remedies, or the misuse of steroids can cause severe damage. Such practices highlight the urgent need for better public health education and access to safe, regulated care. There are lifestyle factors such as smoking, diet that lacks essential nutrients, excessive alcohol consumption, all have been linked to an increased risk of developing serious eye diseases. There are several challenges to eye care in Nigeria. Shortage and misdistribution of skilled eye care workers, worsened by the recent JAPA syndrome, Adepoju et al. In 2011. Poor infrastructure, lack of diagnostic and surgical facilities, geographical, social, cultural, and logistic barriers to service, inadequate training, limited technology and high cost of equipment, the rising insecurity, weak integration of primary eye care into primary health care. Community eye care is a people-centered subspecialty, focusing on primary, secondary, and some tertiary prevention, as well as rehabilitation, awareness campaign, and advocacy. All of these activities take place at the population level. We have several cadres working as a team in eye care. The ophthalmologists are medical doctors with specialization in medical, surgical, and optical treatment. Optometrists deal mainly with refraction and prescription of glasses, and we have opticians who help us to fix glasses. Why are we explaining this? Several people, no matter how highly educated they are, do not know the differences between these areas. Communities are target population with shared needs, cultures, and beliefs, and they are reached through intervention. They may have unique phenotypic or typological features. Sojourning to community eye care service revealed poor access to care, with several documented bizarre ocular conditions and several cases of bilateral blindness from avoidable causes, such as cataract. The Vice Chancellor, sir, permit me to conclude this segment with this community work. I humbly ask from the audience, have you had an eye check this year? Everyone is mandated to check their eyes at least once every year. Early detection saves vision. Secondly, I humbly request that you cover one eye, observe your sight in the open eye. Please cover the open eye and check the second eye. If vision differs between the two eyes, if it's narrower in one, or if your vision is poor in both eyes, get help immediately after this lecture. Blindness remains one of the most dreaded disabilities, yet most of it is avoidable. A friend of mine once called this avoidable blunder. Nigeria reflects this global challenge. Despite advances in surgery, training, and policy, cataract and other preventable causes still account for a high level of blindness. Distinguished guests, my life experiences, including discovering purpose through challenges, prepared me to see the need and to serve the community. To better understand and address blindness at the community level, I pursued a certificate course in community eye health at the Groote School Hospital in Cape Town, and a master's at the London School of Hygiene and Tropical Medicine. I further refined my cataract surgical skill at the Arabian Eye Hospital. In our study at the School for the Blind, Adepoju in the year 2006 found blindness to be avoidable in 77.5% of cases. Majority were from cornea diseases, cataract, and glaucoma, and most were blind from childhood, half before the age of 1, highlighting the urgent need for prevention and early care. At a one-year cross-sectional study at UITH, Adepoju in the year 2005 showed the commonest eye disease to be allergic conjunctivitis, cataract, and glaucoma. These avoidable conditions can largely be addressed at the primary and secondary care level, leaving consultants at the tertiary level to care for complex cases. Unfortunately, this is not our experience. In another study among commercial intercity drivers in Ilorin, Adepoju in the year 2008 found 10% of the drivers had severe visual impairment and found few that were legally blind, and they were still on the wheel. In one of our community outreach journeys, early in the morning, a trusted driver who had taken us to several outreaches began to drive, entering into gutters and holes. He was later discovered to have cataract blindness in both eyes, nearly causing a disaster. He was successfully operated. This underscored the urgent need for mandatory vision tests at driver licensing and at renewals. Cataract remains a global key indicator of eye care services. Developed nations like the United States and the United Kingdom have achieved high cataract surgical rate, 4,000 to 6,000 per million population. India and Pakistan have made significant progress, nearing the WHO target of 3,000 per million population. Low-income countries have rates less than 500. The estimate for Nigeria stands at 300 surgery per million population. Adepoju in 2014 on the study of cataract surgical services in Kwara State revealed a complex landscape characterized by notable strengths as well as significant challenges. While the state had a fairly adequate number of eye care workers, infrastructure, and equipment, 80% of them were situated in Ilorin, the state capital, where only a third of the population lives. This creates a significant imbalance in access to care for the more widely distributed rural population. Despite the issues, the cataract surgical rate rose from 218 in 2003 to 2,417 in 2009. This figure, however, is still far below the 4,000 to 6,000 target needed to effectively eliminate blindness from cataract. Adepoju identified barriers such as high cost, poor access to surgical centers, staff, poor motivation, and lack of patient awareness or support as barriers to service. Many do not know where to go. Many cannot afford the surgery or lack an accompaniment. These factors have kept cataract blindness a persistent challenge. Adepoju and Ilorin et al. In 2009 studied 23 hospitals in Nigeria and Ghana and exploring strategies to increase the cataract surgical rate. The most populous idea was offering rural allowance to encourage ophthalmologists to work in underserved areas. A defining part of my career has been cataract surgery, though through which I have restored vision, advanced surgical methods, trained the next generation, and shaped public health policy. Reflecting on my growth in treating avoidable blindness from cataract, I recall starting cataract surgery with the only option to us at that time, intracapsular cataract surgery, and the popular big avoidable. I later trained in a more refined method of addressing cataract, and again we changed also to small incision cataract surgery and eventually to phacoemulsification. We have found in our studies the global evidence of cataract surgery's effectiveness in restoring sight and quality of life. A major challenge at the start was operating microscopes to be able to do microsurgery at the community level. The base hospital had limited number of microscopes. This is still the limitation at this moment. We adapted an old microscope purchased for less than 50,000 naira, apparently designed to clean instrument. The adapted microscope was modified 2 different stages until we had a functional microscope. Remarkably, this improvised instrument has been used in over 10,000 cataract surgeries at different community outreach programs. I was not born in the era of couching, an outdated, ineffective method, still unfortunately practiced despite poor outcomes. But with all the levels of cataract surgeries that we have learned, have taught and translated this, and we have adapted to the newer method, even in low resource settings. Phacoemulsification, ladies and gentlemen, we're proud to say we're able to do even at the community level. We have major challenge with biometric calculation, a very major step in calculating what lens power we should insert in an eye. Adepoju et al. In 2007 made a study that showed the average IOL power needed, and we got a value of 20 to 22. Ladies and gentlemen, we have gone past that. We now perform biometric calculation in the hinterland, though equipment numbers remains very low. The Vice Chancellor said, our cataract surgical rate have remarkably increased, with over 20,000 cataract surgery performed across communities and hospitals. This effort, recognized with the Global Award by Universities International, was to deliver 1,200 surgeries in a single year, which was concluded in the year 2025. We have also trained cataract finders, friends of the eye, children and community health workers to help detect and refer cataract blind patients. In addition, numerous cataract educational programs have been conducted via radio, TV, village square, community forums, and online platforms. Mr. Vice Chancellor said, permit me to say, Mr. and Mrs. Cataract, the conquest is still on until no one is needlessly blind from this ominous cause of avoidable blindness. We made a film titled You're My Eye in the year 2011, a health education film on cataract. This film received an award from the Ophthalmology Society of Nigeria and the African Ophthalmology Council in 2011 and was viewed by over 10 million viewers, shown in 27 TV stations in Nigeria and in Africa. Our contribution to glaucoma. Glaucoma is a silent thief of sight, leads to gradual visual loss. If untreated, visual loss is irreversible from glaucoma. Frequently asymptomatic in its early stages, glaucoma is a leading cause of preventable blindness, though common in adults, it can occur at any age. In our study of 208 patients, Adepoju in 2015 found that the major pain in glaucoma treatment was late presentation due to poor awareness. At diagnosis, a quarter of patients already had visual impairment, and about 20% are already legally blind in the better eye. Other issues with glaucoma are poor compliance with treatment, limited equipment, high drug costs, counterfeit medication, and reluctance towards surgery. Our contribution to glaucoma care centered around distribution of widely circulated eye health leaflet, production of an eye health film called the Still Water, which was widely viewed. We had a serial TV and radio eye health lecture development. We also developed a local fundus camera for community level of detection. We need to further conquer glaucoma blindness by ensuring good knowledge of the disease in the community, encourage early presentation, and strict compliance with care to reduce glaucoma blindness. The regular playout, ladies and gentlemen, is a late presentation all the time. A scenario signified by Mr. A1, first seen in 2012, was diagnosed with glaucoma, defaulted from follow-up, and after one visit, returned 9 years later, blind in both eyes. This avoidable blunder must stop. Adepoju et al. Contributed to normative values of corneal diameter and intraocular pressure ranges for Nigerian newborns, providing a key diagnostic tools. Faced, as usual, with limited resources, we improvised a trabeculotomy using a 27-gauge needle, enabling sight-saving surgeries in rural settings. A practical example of innovation driven by necessity. The 1-week-old baby was successfully treated among several others. Our contribution to corneal ulcer. Corneal ulcer is a major cause of avoidable blindness and visual impairment worldwide. In a retrospective study at the University of Ilorin and another study in 2023, we had a national corneal ulcer profiling, and this was linked to occupational hazard amongst farmers and traders. Timely intervention is crucial to prevent vision loss and restore sight. The findings also revealed late presentation by patients, over-the-counter medication, and use of several injurious substances and herbs as core risk factors. To reduce the high number of corneal ulcers and perforations seen at the hospital, Adepoju and Adepoju et al. Focus on how to minimize corneal ulcer scarring caused by harmful traditional eye medications. The work contributed to the understanding of this issue and recommended a comprehensive multifaceted approach. Finally, we suggest a collaboration with traditional healers to help modify or discourage harmful practices from within the community. As part of primary prevention, which involved health education, we created posters and several health information materials to educate the community. In tertiary prevention, we are evaluating the production, storage, and use of amniotic membrane transplantation in management of corneal ulcer. Combining health education, early diagnosis, and this intervention, we can significantly reduce blindness from corneal ulceration. Ocular injuries are another leading cause of ocular blindness and a common emergency in eye care. I recall a case involving a young Fulani herdsman with a ruptured right eye from a cow horn injury. 3 weeks later, he ruptured the left eye again from another cow horn injury. A young lady beaten by his brothers had both blindness from a preventable cause. Adepoju et al. In 2020 highlighted global prevalence of ocular injury, and we documented male preponderance and a older age distribution. Common causes include occupational, domestic, road traffic accident, and assault. Outcome of ocular injury depend on the extent, but as well as the promptness of treatment. Preventive measures, health education, legislation, and advocacy are crucial. Chemical eye injuries were reviewed in the year 2007. We find that the most injurious were accidental, primarily work-related, while a third was from assault, leading to bilateral blindness. Acid and alkaline were the main agents. Findings underscore the need for improved occupational health policies and better institutional preparedness for ocular injury. In 2014, Adepoju et al. Demonstrated that ocular injury remains a significant cause of monocular visual impairment and blindness. The 15-year retrogressive survey examined the common risk factors, psychological effects, and preventive measures of bilateral blindness from ocular injury. Males, again, are 3 times more likely to have ocular injury. Chemical eye injury from car battery water was the leading cause. This finding highlighted chemical injury as a preventable cause of bilateral blindness, reinforcing the need for education and legislation. In addition to numerous lectures and seminars, we produced a book, Stop the Madness, a widely circulated film on ocular injury also, and high health film to show injuries are found on our social media page. Contributions to community engagement and outreaches. I'm glad to say that the proportion of people needing eye care who present to hospital is low. And realizing this, we decided to take eye care to the hinterland. Many at the community level have poor or no access, including those in urban slums. The community experience also revealed groups who are well-to-do but for logistic reasons resorted back to medical tourism. But communities are not helpless. They hold within them resilience, goodwill, and capacity. With the right guidance and support, they can become powerful partners in preserving vision and preventing blindness. A surgeon in community eye care was largely by medicine based. At the time, community practice was new, and the culture was to wait in hospitals for patients, and they were not coming. A respected senior once told me, "Why go to community? Patients come to us." Mr. Vice Chancellor, sir, we changed that culture. Community outreach later became the main source of cataract patients and other patients for base hospital surgeries. We developed innovative solutions including production of local touches, construction of locally made table stands and pinhole, built snelling chart constructed from wood and metal aluminum, improvised refraction lenses from broken frames stacked in different powers, modified microscope as earlier explained. In one of our outreach, ladies and gentlemen, when the step down was forgotten in the base hospital, we powered the operating microscope with a car battery and successfully operated on 13 patients overnight. That became a sometimes go-to when we operate at the community level. Sometimes, movement on bad roads, equipment damage do occur in transit, such as a personal paper machine recently repaired at a very great cost. These experiences underscore the need for a dedicated mobile high hospital van. Mr. Vice Chancellor, sir, if we are not at the level of a flying high hospital like the Orbis, which we have hosted twice in Kwara State, the state can at least have a mobile van to deliver community eye care to any part of our state. The poor state of the primary eye care centers was also a major challenge. The recent government rehabilitation has improved several facilities, and we are very grateful. Mr. Vice Chancellor, sir, I have seen firsthand the heavy burden that avoidable blindness faces on individuals, families, and communities. Eye care is not just a clinical service, but is deeply connected to public health and social justice. True impact lies in public health ophthalmology, reaching those who cannot reach us. To bridge knowledge and access, we provided community eye care in schools, in clinics, town halls, fairs, villages, squares, markets. We targeted welders, chemists, drivers, students, organizations, people who might never have had access to specialist care. We used every opportunity, World Sight Day, World Glaucoma Week, Diabetes Day, Children's Day, weddings, even funerals for aged parents, to advance the quest and conquest of community eye care, always keeping our eyes on the gas. Through collaborations with community stakeholders and cross-sector partnerships, my teams have screened and treated thousands of individuals in rural and underserved areas. This effort has facilitated over 20,000 surgeries, screened over 300,000 persons, and provided glasses to several, restoring vision as well as improving livelihood, dignity, and hope. Notably, we have on several occasions operated on siblings on the same day and couples on the same day. Early clinical practice exposed me to the inequalities in eye care. While urban centers had specialized services, rural and underserved populations were largely neglected. This disparity compelled us to look beyond the operating room to public health strategies capable of scaling vision restoration and blindness prevention nationwide. The divide between urban and rural access, persistent gender inequalities, limited eye care services, affirm community-based outreach is not optional but essential. Guided by this convention, we have led more than 1,000 community outreaches across Nigeria, including repeated visits to towns and villages in Kwara, Oyo, Ogun, Ondo, Lagos, Niger, and Imo State. These figures represent life transformed, families restored, communities empowered. In one outreach to Okigwe in Imo State, a 13-member team conducted this cleaning under armed security, reflecting the growing challenge of insecurity in our land. A gentleman walked in several years back beyond the 9 a.m. cutoff. The regulation required that he must be turned away. Mercy prevailed 2-kilometer journey. I later found out he was the manager of Dam. He lamented the absence of eye care in his community and the dire need for eye service. He appealed that we come to examine his workers, which marked the beginning of a monthly visit to Nikusa for over 20 years. This experience highlights the need for people-centered system, adequate manpower, and accessible eye care. By bringing services closer to underserved groups, especially women and children, integrating preventive, curative, and rehabilitative care, we can bridge the gap between the need and access. The battle against avoidable blindness will be won, not in urban hospitals, but in the communities where the burden is the greatest. Achieving this requires integrated strategies where research informed practice, policy support implementation, and innovation extend care to those in need. Community eye care is demanding. Teams often work 2 to 3 days delivering what will have amounted to a month's work in a hospital setting. With the support of sponsors and local partners who provided logistics and subsidized consumables, this mission has been sustained. Mr. Vice Chancellor, allow me to share 3 experiences that illustrate the transformative power of this work. A deposed emir from Yubusa, blind in both eyes, regained vision after cataract surgery. At his follow-up visit, he smiled and proudly introduced his new wife, a new chapter enabled by restored vision. In another instance, a 2-week-old baby with congenital glaucoma underwent emergency trabeculectomy in a rural community using an improvised needle. The site was preserved, and today I believe that boy is in our midst. Finally, in Ofa, a deaf and a mute farmer who had gone blind underwent cataract surgery. The morning after, when his sight returned, his joy was so profound that he spoke for the first time. The picture of a young man we're seeing, whose self-esteem has been eroded by a facial mask he carried for years due to lack of access and funds, with support raised through some of our supporters, particularly who regularly come to the aid of such individuals. He underwent surgery. A few weeks before I finalized this lecture, he sent me the photo with a short note, back in 2019 and now in 2025. Another unforgettable story is that of a young woman bilaterally blind from cataract who had just given birth. She transferred several kilometers to attend an outreach. After surgery restored sight, she burst into tears because she saw the face of her baby for the very first time. The list of such stories is endless. The impact of community eye care is palpable as darkness itself. Yet the need is immense, and the gap between communities and available services remains very wide. We must mind the gap, mend the gaps, and bridge the gaps. And every one of us here seated will have a role to play. A vital part of community work is advocacy and fundraising. In a multi-community study 2013 to 2019, Adepoju in 2022 screened 13,661 individuals across 235 visits in 65 communities in Kwara State. The study found that community-based organizations can provide critical financial support, which grew immensely within the number of years that the program lasted. This enables subsidized care and helped meet outreach goals. However, funding is still insufficient, as services provided always fall short of the actual needs. Over the years, our community outreaches have been made possible by the generosity and sponsors of partners, including but not limited to Professor Nambo, Ojuna, Odu, Orangofos Heritage, Feyi Ventures, MD medical students. The list is endless, and we say a big thank you to them. Cultural belief and traditional practices can be a significant barrier to eye care. Health information leaflet and media content were created to help people make informed decisions about their eye health. I've mentioned the 3 things earlier. This effort, combined with my social media campaign, has helped grow an online audience to over 29,000 subscribers. The advocacy effort also extends to combating harmful traditional practices like couching and other self-medication, including traditional eye medication, which have persisted despite overwhelming evidence of their dangers. We had a program called Sighted, Preserving Vision, Restoring Sight, a serial television series featuring consultant ophthalmologists across Nigeria, providing educational segments to raise community awareness. By sharing expert knowledge in an accessible format, the program has helped to bridge critical gaps in public understanding of eye health. In recognition of this effort, Mr. Vice Chancellor, we have received several awards, including for innovation in blindness prevention and for leadership in human capacity building, both nationally and international. The real challenge, however, is not the absence of solution, but the lack of access to them. Overcoming avoidable blindness demands the collective commitment of all stakeholders to close this gap and bring care within reach for every community. Training of healthcare workers and capacity development. In one of our research on human resource development for Vision 2020, Adepoju in 2011 identified critical gaps in the staff mix and maldistribution of available IS workers in Nigeria. In response, we focus on strengthening capacity at every level of IK. One major emphasis has been the training of healthcare workers at the grassroots. For example, we had 48 primary health workers who were trained to serve as primary IK workers across 12 centers in communities such as Isie, Okeho, Erile, Unity, Ptosis, Kulende, Alanomi, Ibadan, Ajashe, and Idapo. Similar initiatives extended to community health extension workers in Wawa and in Nibusa. To reinforce this effort, we developed training manuals, published a book on primary eye care, produced instructional flex materials on common eye diseases, and established referral pathway. A unique innovation in this training was the use of a song as a teaching tool, and we asked the trainee, show them what body, and then they respond if they can understand and identify these blinding conditions and take necessary steps. I've had the privilege of developing Nigerian curriculum for public health technology, thereby shaping the formal training of future practitioners. We also co-authored a book for medical students, a textbook of ophthalmology with Professor Palmer and Professor Feyi, actively integrated students into community outreaches, where they were not only taught but also sponsored programs as part of their academic projects. Perhaps the most fulfilling aspect of my journey has been the mentoring of the next generation of ophthalmologists as a teacher, an examiner, and a supervisor. It was privilege to me to be among the pioneering participants of African Ophthalmology Council Leadership Development Program, later serving as a faculty member and eventually its head. I was also honored to be the first African ophthalmologist selected for the American Academy of Ophthalmology Leadership Development Program, where I received the AOLDP award. I saw my sojourn into ethics. My journey into ethics began several years ago with my appointment at the UITH as a member of Bar Ethics Committee, where I served for 4 years before becoming the chair of the Research Ethics Committee. Those 8 years proved invaluable, shaping my knowledge and practice, and expanding my teaching and training in bioethics. This role involved reviewing proposals from students, doctors, consultants, international collaborators, including clinical trial protocols. I later became the first vice president and subsequently the president of the Bioethics Society of Nigeria. This position deepened my understanding of both the scientific and ethical dimensions of research. Reviewing proposals often demanded months of effort, yet broadened my perspective and enriched my scholarship. I remain hopeful, sir, that in the future, such critical work will be formally recognized and rewarded, reflecting its central role in advancing ethical research in Nigeria and beyond. We produce an ethical review guideline on biomedical research, proposal writing, and several other information. My community service. Beyond academia and clinical work, I remain deeply committed to community service. Faith. I served as a pilgrimage ambassador leading groups to Jerusalem and Jordan about 5 times. I was also appointed by the executive governor of Parasite as a 12-member Interreligious Peace Committee. In my local assembly, Abundant Life Church, I've been privileged to be a deaconess, a pastor, and later a reverend. I also hold the office of provost at the Bible College Outreach. My venture into drama. My passion for drama began in early childhood. I joined the Victory Drama Group of Abundant Life Church and later Amsterdam. Since then, I've had more than 150 Christian films and several stage demonstrations. The recent being Inaugural as part of Adepoju. I sought to bridge my drama ministry with my medical profession, leading to innovative productions that combine high health advocacy with faith-based messaging. Academic and professional leadership, our past director, Meryl, international coordinator for the UC's Plus Consortium. In UITH, I had various leadership roles, including facility development. I was past chairman and vice chairman of Medical and Dental Consulting Association of Nigeria, past chairman Nigerian Public Health Ophthalmology, president Bioethics Society of Nigeria, chairman Women Ophthalmologists of Nigeria, faculty member, treasurer, and examiner at the National Postgraduate reflections that have profoundly shaped my journey. Eye care is not only about the patients who find their way to the hospital, it is equally about the many unseen, unheard, underserved in our communities. Clinical care remains essential, yet we must remember that less than 1 in 3 people who needed our service ever reach us in the hospital. Every case that walks into the clinic is a reminder of the many more waiting silently in remote villages and urban slums. I stand before you today, deeply grateful for my critique support, my teachers, my mentors, my collaborators, the students, the patients, and the communities, each of whom have left an indelible mark on my story. I remain committed to the path of service, scholarship, and stewardship. In my quest and conquest of community eye care, there are gaps: human resource adequacy, distribution and mix, poor access due to distance, cost and other logistic reasons, equipment and infrastructural inadequacies, inadequate training and retraining facilities, poor high health knowledge. These we have mended to ensure improved access to eye care by all, and in particular the people at the community level. Together, let us continue to restore vision and renew life. For me, preserving vision, restoring sight, is not merely a slogan. It is my life work, my calling, and my charge to all of us. As we look forward, I envision a Nigeria where no one is needlessly blind from preventable causes. A health system where the eye care is seamlessly integrated into primary care, and a future where community-based eye health thrives as a shared responsibility. Mr. Vice Chancellor, sir, from my experience, permit me to make these few recommendations. We must have decentralized services. Economic and social development of rural communities should be decentralized to make life in rural areas more attractive to health workers. We must empower local government as they are closest to the community to lead the development effort. While planning can be national, the execution must be at the local level. We must have institutions adopting. Every educational and service institution should adopt 1 or 2 nearby communities and be intentional about their development and service delivery. We must integrate primary eye care into primary health care. We must work on public awareness and education, foster collaboration. There should be continuous training and retraining of eye care workers. Individual philanthropies are encouraged to support eye care by organizing screening and community care for indigent persons. Celebrating milestones or honoring loved ones should be done by sponsoring sight restoring activities rather than being limited to traditional ceremonies. There must be public policy change and legislation against couching, including the moderation and regulation of other harmful traditional eye practices. Acknowledgement. Eternal Father, I give you praise, glory, and adoration. Where will I be today but for your unfailing love and care? My life is a testament to your grace, mercy, and divine guidance. Through every stage, you have carried me, and I return all glory to you. I remember with deep gratitude my parents of blessed memory. In the year 2000, when I requested for my abduction, being heavily pregnant, I feared my belly might distract my examiner. Professor Fawole, I went way back. You did not warn me how painful induction would be. I forgive you, however. That young boy is now 24-year-old. Mr. Freshbrain, Adepoju Victor. To my senior sister, Mrs. Felicia Oyeleke, you stepped into the role of our parent without hesitation. I remember all the financial sacrifice. I say thank you. To our only brother, you traveled all the way from US to be here with your lovely wife. You have become like our mother. Thank you, Mama. Your immense care and generosity constantly remind me that I'm forever your little sister. Mrs. Bosade Jodala, thank you for your unwavering love, prayers, and concern. The good Lord bless you. I count it a privilege to have been born thrice. First into the Ilorin family, second into the body of Christ in 1988, and third into the family of Adepoju. Ladies and gentlemen, I do not have in-laws, but I have mothers, fathers, brothers, and sisters-in-law. Senior Apostle Adepoju, okay, Mama Adepoju, I love you all and you know it very well. I remember many years back when I was still doing residency, Papa, you locked me in your room. I said, Makawe, I'll tell them I sent you on an errand. Now that sacrifice I really used it, and I say thank you. To all my teachers, both primary, secondary school, I thank you all. I thank all my students from the primary school and OBHs that are here. I bless you for finding time to listen to this lecture. I thank Professor J.O. Anyan, Professor P.C. Ogushina. These two elders, on different occasions, called me and said, I'm adopting you as my daughter. I appreciate that adoption. It was an answered prayer. I thank all my international mentors, Sri Shankar, Dr. Daksha Patel, Dishari, Dr. Colin Cook, and several others. To my ophthalmology mentors and trainees, so numerous, Professor Victoria Khan, Dr. Isaac Iyane, Dr. Ayodeji of Blessed Memory, Professor Adorike Bayology, Professor Saho, Professor Owosu, Professor Caroline, Adjoti, Elsie, Samaya, several of you have all contributed immensely to my life, and I say thank you. To my esteemed colleagues and senior professionals, Professor Ero Mahmoud, Dr. F. Olatunji, Dr. Dejiajo, Dr. Pino Abikore, Dr. Suleiman Zubal, Dr. Victoria Olatunji, several of you, I'm so grateful. I thank Professor W.P.R. Johnson, Professor Luke Edubola, Professor Ayorin, Professor Agaja, Professor S.A. Kuranga. The list is endless, but deeply in my heart, I appreciate you all. I appreciate all my senior friends and supporters, Professor Adeyemi K.S., Dr. Olatunji Oladokunsi, Professor Okeshino, Professor Ero Mwalomo, Dr. Abdulrazak Jimo of Blessed Memory. I thank all my collaborators, Odu, Ojuna, Kanji Medical Center, Igosin Development Association, Ekinle Development Association, Kanji Dam, Zoba Community, and all my professional families. To the University of Ilorin, the Vice Chancellor, past and present, I thank you all for your immense contribution into my life. To the people of Igosin and Yorile, I thank you. Alumni of ABU, OBHS, thank you very much for all your contribution into my life. I must say a big thank you to the Ansidron family, ably led by Evangelist Mike Bamiloya and his wife. Thank you for your ministry partnership and for using drama to touch lives through our work. Evangelist Mike Agbola and his wife. I thank my abundant life gospel ministry, my church family, led by our able mama, Reverend Dr. Jane Onolapo, ably represented here today by our state pastor in Oyo. Thank you for finding time to be here. Reverend and Reverend Mr. Olaranko, Reverend Ben Bade, and all the other pastors and deaconesses and reverends in Abundant Life Church. I honor this heritage. To my wonderful community eye care team, Lecturer Amodu, Mrs. Awolola, and several others, we have walked through all the towns and cities tirelessly. The good God reward every one of you. I thank all my friends, Dr. Bode Obujamiwa, Reverend Mrs. Cynthia Salami, Reverend Mrs. Lauye, Dr. Mrs. Adepoju, and a host of others. Dr. Mrs. Turotoye, thank you very much. To our children, Pastor and Pastor Mrs. Olagoshu, Mr. and Mrs. Comfort Olaroye, lawyer and engineer Adewale, Barrister Kabua, and my son-in-law also Kabua, Engineer Adepoju, Dr. Mercy Adepoju. Thank you for making children feel as easy as ABC. And to our lovely grandchildren, Adewale Araire, Tiwade Sire, and Ifem Chukwu Akabua, and those still on the way. I'm savoring every moment with you. You bring the joy and ease while raising the parents. And finally, I'd like to reserve the best for the last. I wish to especially acknowledge my husband, Reverend Emmanuel Adeyemi Akonwu Adepoju, my envy, my dearest friend of 43 years, my life partner of 33 years. Your unwavering love, patience, prayers, and encouragement has been the bedrock of my life and career. We transverse the community I care together through every quest and conquest. You have stood beside me with quiet strength and unwavering belief. You are a rare breed, a quality man who fears no equality, a great supporter of the girl child, in truth and in spirit. This milestone is not mine alone, it is ours. I honor and celebrate you today with the deepest gratitude and love. I want to thank every one of you for listening, and God bless you all.
On behalf of all of us, we want to thank our prominent inaugural lecturer, Professor Feyi Grace Adepoju, for taking us through the conquest of community and minding the gaps. Congratulations. And on our behalf, we want to appreciate our guests this evening, former Vice Chancellor, Adepoju University, Professor Noah Yusuf, thank you for coming. Professor Ilorin Yusuf, CMDUITH represented. Professor Udubu Abayo, I'm not sure, former Davis Academic. Professor Sulaiman Folonshaw Ambali, former Davis Management Services. Professor Abdulwahab Olanwaju, former University Librarian and Chairman, Library and Publications Committee. My dear wife, Ajamu Bata, thank you for coming. Our father, Professor B.J. Oju, the former provost, we appreciate you, sir. We want to warmly appreciate the presence of Professor Landmark and Dizzy from Cape Peninsula University of Technology, Cape Town. Thank you. Dr. as Director, African Center for Other Research, Ilorin. Professor Dennis Adepoju, the Provost College of Health Sciences of African University. Thank you for coming. Our Royal Fathers, His Royal Highness Oba Adesoye Adebowale Jr., Ẹlẹ́rìn ọ̀fẹ́ ilé Kábíyèsí. His Royal Highness Oba Abdulrazak Adegboyega Afolabi Iyola Shentri Lójúbọ Kábíyèsí. His Royal Majesty Oba Dr. Abdulrazak Adebayo Elufemi Lóyè. Thank you for coming. We look up to you. His Royal Majesty Oba Alhaji Buhari Adeniyi Idi Mijabo Kingdom. Thank you for coming. His Royal Majesty Oba Omeniyan Mosiola, the religion of John local government. Thank you for coming. Let me warmly celebrate and welcome the Managing Director of Medfund, Mr. Sawyer. Thank you so very much for joining us. Our clergymen, too numerous. This is a day of the prayer warriors. We appreciate and thank you all for being here. We appreciate Dr. E. Adeyemi Oniwo of Okeba and Obamania. Thank you so very much for joining us. We appreciate the teacher and non-teaching staff of the university, the members of the press, Senator Yo, we recognize you, Dr. Pastor Mrs. Olotu, we appreciate you. We also acknowledge the presence of Professor A. Fawole and Professor Mrs. Fawole who are joining us online. The inaugural lecturer has forgiven Professor Fawole and refused to get introduction. And we also appreciate Evangelist Mike and Evangelist Gloria Abamiloye, Chairman, Bill and President in Zion Faith Ministry. We recognize the brilliance of the inaugural lecturer who are here today in spirit. We recognize the siblings of the lecturer, Mrs. Felicia Oyeleke, Ms. and Mrs. Alexandra Alwamide, Mrs. Bose Alibona. Thank you so very much. We recognize and appreciate the children of the inaugural lecturer, barrister and engineer. Please, Adepoju. Sorry, Baba Adepoju. Apologies. Thank you so very much for coming. Parents, because welcome, sir. Thank you so very much. Mama, comfort Adepoju. Thank you. children of the inaugural lecturer, barrister and engineer Peace Adewale, thank you, congratulations. Mr. Alonso and Barrister Blessing Akabua, thank you. Dr. Mercy Adepoju, Engineer Victor Adepoju, Pastor Joshua and Pastor Mrs. Grace Oladoshu, Comfort and Kola Olanwoye. Since the inaugural lecturer saved the best for the last, I also recognize and appreciate the spouse of the inaugural lecturer, my own brother, Reverend Emmanuel Adeyemi Adepoju. And of course, we thank each and every one of us that has taken time to be here this evening, especially the area of Nelfon. Thank you so very much for coming, sir. I hope you came with billions of naira. Thank you.
Shall we rise for the university anthem? Again, ladies and gentlemen, we want to thank you very much for being part of the 290th in the series of inaugural lectures of this university, delivered by distinguished Professor Feyi and Adepoju, the first female ophthalmologist in Paris. Obviously, from Ilorin, also very much welcome. The Vice Chancellor is saying thank you for coming. To all our KBCs in the house, thank you very much. We appreciate you. To all our distinguished guests, please do remain where you are. The Vice Chancellor, former Vice Chancellor of University, Professor Noah Yusuf. You're welcome, sir. The wife of the Vice Chancellor, First Lady, University of Ilorin, please let's have the immediate family of the inaugural lecturer to follow the procession. Thank you, thank you. And ladies and gentlemen, thank you for coming. I told you of the 50th anniversary of our university. We have the chair of the committee, Professor Mokolu. You're welcome.
Congratulations once again, sir.
Now, can you look at this camera, please? Yeah. Mommy. Okay.
Reverend.
Sorry.
It's not the finishing, it is the person serving.
Oh yeah.
Yes,
Chief on testing.
So, what's your father? Oh, you got for me?